Good morning. My name is Dr. Louise Connell. I'm a GI medical oncologist from Memorial Sloan Kettering Cancer Center in New York. And I just wanted to mention some of the key highlights in terms of the colorectal cancer abstracts that were presented at this year's annual meeting. I think as an underlying focus here, it's important to realize that we are beginning to gain a better understanding of the various molecular subtypes involved in our patients with colorectal cancer. And we're trying to move away from a one-size-fits-all approach to better personalizing treatment for these patients in terms of individual drug choices, and also looking at the sequencing of these drugs in first line, second line, third line, and so on to optimize results and survival for this patient group. Some of the interesting studies that were presented, of course, the one that everybody is talking about is the final results from KEYNOTE-177. So we knew from previously reported data that pembrolizumab was superior to chemotherapy in the first line setting for patients with MSI-H or MMR deficient colorectal cancer. And it was established as a standard of care based on the data which was published in the New England Journal of Medicine. At this year's ASCO, what was presented was the final overall survival data. And what we saw here is we did see a significant trend towards improvement in overall survival, but it did not meet the pre-specified criteria for superiority. So while the overall survival was negative, with a dual primary endpoint of PFS and OS, pembrolizumab is still considered standard of care now and going forward for patients with MSI-H or MMR deficient metastatic colorectal cancer. Another interesting abstract from my point of view was looking at maintenance chemotherapy. This is a question that comes up all of the time in routine clinical practice. You see patients who have a fantastic result to first-line chemotherapy. The question of continuing them on a maintenance regimen versus giving them time out from chemotherapy in terms of quality of life, enjoying their life, a break from the hospital. And the trial presented here was FOCUS-4N, which looked at oral capecitabine versus active monitoring. As with most maintenance trials in colorectal cancer, the study essentially showed an improvement in progression-free survival, but did not show any improvement in terms of overall survival. Also, based on the results that were presented, there was no difference in terms of quality of life. I think what this trial allows us to do is to discuss the choice with the individual patient in terms of continuing on an oral chemotherapy regimen versus taking a complete break from treatment. And what was interesting with this trial is that when they compared it back to previous maintenance trials, we weren't using the bevacizumab component, which is the more costly drug and also the one that requires presence at the hospital. So it was a less is more approach in terms of maintenance treatment, and definitely informed the discussion with our patients in clinic in terms of maintenance treatment going forward. In terms of second line, then typically patients either have FOLFIRI or FOLFOX in the second line, assuming that they've had the opposite drug combination in the first line setting. The TRUSTY study then was looking at an alternative second line treatment approach, trifluridine tipiracil with bevacizumab versus an irinotecan based combination in the second line setting. And the argument here was that irinotecan is a drug that can have side effects such as diarrhea and alopecia, which can impact quality of life, as well as daily functioning for patients. Effectively, what was seen in this study is that they could not show non-inferiority in terms of overall survival for the experimental drug combination of trifluridine tipiracil with bevacizumab versus our standard of care irinotecan-based approach. And essentially, we should not defer from the current standard with regards to this. Certainly, trifluridine tipiracil is an attractive option for certain patients in the third line setting, but not currently in the second line setting based on this study. And then finally, coming back to this concept of personalizing care. So we have these distinct molecular subgroups that we know about in colorectal cancer. We have very good data in terms of KRAS. Now we have increased data in terms of the personalizing treatment for MSI-H tumors. And the final study that I want to highlight looked at HER2 expressing metastatic colorectal cancer. So this was the DESTINY-CRC01 study, which looked at a monoclonal drug antibody conjugate trastuzumab deruxtecan in the third-line setting for patients with HER2-expressing disease. So what was important about this study was that there was 3 cohorts of patients, depending on the level of HER2 expression. The first cohort and the patients who seemed to gain the most benefit from this drug option were patients who had IHC 3+ HER2 expressing disease. And also what was interesting is that in addition to patients being heavily pretreated with our standard drugs, in this primary cohort, about 30% of patients already had received previous anti-HER2 therapies. And what we saw is we did see responses despite this. There was a 45% objective response rate in the cohort A of this study, that is the high HER2 expressing tumors. It's a very attractive option for these patients. And definitely we're seeing better survival results than some of our current standard of care drugs, such as regorafenib or trifluridine tipiracil. An interesting adverse event then that was seen was interstitial lung disease. And this is important to note in any patients on this drug combination, but effectively based on this data, it's an attractive option for patients, and it does merit further exploration in that small proportion of patients that we see with HER2 positive disease. I hope this has been informative. I think this was a very interesting meeting, and I think again what to take from the meeting was this concept of further personalizing care for patients, the importance of next generation sequencing in patients, that it's now mandatory in any patient with metastatic colorectal cancer to check the microsatellite status to inform treatment decisions. And also the concept of how best to sequence drugs in this patient population in an effort to optimize survival for these patients. Thank you for your time.